Good morning, everyone. My name is Rana. I'm one of the Echo Fellows, and today we're going to be discussing an interesting new entity called Eclipsed mitral regurgitation, which has been recently described in multiple case reports. So eclipsed or paroxysmal mitral regurgitation has been described as a transient and reversible severe mitral regurgitation happening in patients with preserved LV function and leading to acute heart failure symptoms. The condition is characterized by a sudden defect in mitral valve coaptation, but the exact mechanism remains unclear. However, ischemia is a suspected factor. This here is a recent case that was published in Circulation discussing a case of severe eclipsed mitral regurgitation. Essentially, the authors present a case of a 49-year-old man with a history of difficult-to-control atrial fibrillation who presented with recurrent episodes of shortness of breath and chest pain. And despite pulmonary vein ablation and the optimization of medical therapy, his condition worsened. So the patient presented an acute decompensated heart failure, his BNP was elevated, and his troponin was also high. He underwent an echo, which essentially showed normal biventricular size and systolic function with mild mitral regurgitation, and his angiogram did not show any significant coronary artery disease. He was referred for a stress echocardiogram, and essentially at rest, the echo showed mild mitral regurgitation, but at peak exercise, the patient experienced symptoms including chest pain and shortness of breath, and he was also noted to have a significant increase in the severity of his mitral regurgitation at peak exercise, and there was also an increase in the maximum velocity of the TR jet, suggesting the development of pulmonary hypertension. A transcatheter edge-to-edge repair was decided for this patient, given evidence of intermittent severe mitral regurgitation. For further evaluation in this case, they decided to do a coronary angiogram with vasoactivity testing, and essentially with acetylcholine injection, the patient was noted to have a severe vasospasm of the LAD, and he also developed severe mitral regurgitation. There is evidence of severe apical tethering of both mitral leaflets, resulting in a large coaptation defect that was seen on 3D TEE. There was also a significant drop in the LVEF. There was also a significant increase in the mitral tenting height and the mitral tenting area. And as a result, the team decided to cancel the procedure and they opted instead to optimize pharmacological treatment for coronary vasospasm. So I thought this was a nice case as it highlights that severe mitral regurgitation can have a transient nature to it and can be easily overlooked. And as we all know, mitral regurgitation is dynamic and the severity varies at different loading conditions. And as a result, we should have a thorough diagnostic approach in patients with unexplained symptoms. Since we talked about a very unique form of functional mitral regurgitation, I'll take this opportunity to briefly discuss functional MR more broadly. So functional or secondary MR is defined as mitral regurgitation caused primarily by abnormal left-sided heart function as opposed to intrinsic structural valve changes. Functional or secondary MR has been shown to be associated with increased cardiovascular morbidity and mortality. And we have two broad categories of functional MR, and this includes ventricular functional MR and atrial functional MR. Ventricular functional MR is related to an imbalance between mitral leaflet tethering and closure forces, and this leads to poor coaptation. The pathophysiology of ventricular functional MR is most often the result of abnormalities in left ventricular function and remodeling seen in either ischemic or non-ischemic conditions. On the other hand, a more recently recognized entity is atrial functional mitral regurgitation, where you have a normal left ventricular function and geometry, but the regurgitation is related to mitral annular dilatation. A normal mitral valve has concavity of the leaflets towards the left ventricle, as shown here in this figure. So normally the LV systolic pressure causes the leaflets to concave towards the LV. Here in atrial functional mitral regurgitation, the mitral valve loses its concavity, and this is because of severely enlarged left atrium and mitral annulus. So the mitral valve leaflets are flattened. On the other hand, in ventricular functional mitral regurgitation, we typically see leaflet tethering, and this is mediated by an enlarged LV with global or regional systolic dysfunction, along with displacement of the papillary muscles. It's important to note that in atrial functional mitral regurgitation, the mitral valve coaptation is usually not displaced apically. On the other hand, the mitral valve coaptation is apically displaced in ventricular functional mitral regurgitation. This here is for the C3s writing their exam this year, the Carpentier classification, which is essentially a system used to describe mitral regurgitation based on the motion of the mitral valve leaflets. In type 1, the leaflets move normally and the MR comes from annular dilatation or leaflet perforation. Type 2 is characterized by excessive leaflet motion, and this can be seen in mitral valve prolapse or flail. In type 3, we have leaflet restriction, and this can happen either in systole only, and this is called 3B, usually happening in ischemic tethering. And the tethering can also happen in both systole and diastole, and this is classified as 3A, and this is usually due to rheumatic heart disease. The focus of our topic is functional mitral regurgitation. So atrial functional MR is classified as Carpentier 1 due to annular enlargement. On the other hand, ventricular functional MR is classified as 3B, which is related to tethering and restricted closure of the mitral leaflets in systole. So ventricular and atrial functional MR are fundamentally different and they have very different mechanisms. In atrial functional MR, you'll have poor leaflet coaptation due to insufficient leaflet coverage to compensate for annular dilatation. On the other hand, the mechanism in ventricular functional MR is mediated primarily by displacement of the papillary muscles or an abnormal geometry of the left ventricle, leading to tethering of the mitral leaflets. The new ESC valve guidelines outline criteria to help distinguish between ventricular versus atrial secondary mitral regurgitation. There are key criteria and there are additional echo criteria and additional clinical criteria. And they highlight that the key criteria has to be fulfilled, but the additional echo and clinical criteria help support the diagnosis. So the key criteria to define atrial SMR include an ejection fraction of 50% or higher without regional wall motion abnormalities, no or mildly dilated LV cavity without leaflet tethering, mitral annulus dilatation with an anterior posterior diameter of at least 35 millimeters, as well as an enlarged left atrium with a volume index of more than 34 mLs per meter squared. On the other hand, when we look at ventricular SMR, the key criteria includes a reduced LV systolic function, with or without wall motion abnormalities. And another key criteria is the presence of restrictive leaflet motion with tethering while having a normal leaflet morphology. There is a strong link between atrial fibrillation and the development of atrial functional MR, and this is mediated by left atrial mechanical dysfunction, left atrial fibrosis, and electrical remodeling, and this eventually results in left atrial and annular dilatation and eventually leads to the development of atrial functional MR. You could also see it in the setting of a normal sinus rhythm, and usually it's seen in patients with HFpEF, which leads to increased LA pressures and left atrial dilatation. Atrial functional MR is increasingly recognized as a clinically important entity. Its prevalence is estimated to be approximately 7% among patients with atrial fibrillation. In addition, up to 50% of patients with HFpEF were found to have some degree of atrial functional MR. Usually, the jet of atrial functional MR is central in character. However, in more advanced stages of the disease, with extreme dilatation of the left atrium and annulus, there is an eccentric form of atrial functional mitral regurgitation, and this is known as hamstringing of the insertion point of the posterior leaflet. And this has been looked at in histological slides. So in severe cases of left atrial dilatation, the annulus itself slides onto the crest of the LV inlet, and the posterior mitral leaflet, as a result, is pulled along with it. And this leads to tethering of the posterior leaflet, and mitral regurgitation in this case will have an eccentric appearance. This here is a TEE in a patient with severe left atrial dilatation. And as you can see, there's restriction of the posterior mitral leaflet in the absence of any regional wall motion abnormalities. And this is an example of atrial functional MR where the jet is eccentric. Just to touch on the pathophysiology of atrial functional mitral regurgitation, in theory, the heart valves adapt to the expansion of the surrounding structures, and this is called the endothelial to mesenchymal transition. It's a complex cellular process. So the leaflets are trying to elongate to compensate for worsening annular dilatation, and the regurgitation takes place when the compensation is insufficient to compensate for the degree of annular dilatation. In addition to left annular dilatation, there is evidence showing that annular contraction is impaired in patients with AFib and atrial functional MR, and this leads to worse mitral regurgitation severity in atrial fibrillation compared to normal sinus rhythm. This here is a very well-conducted study that recruited 53 patients with atrial fibrillation who were scheduled to undergo an elective cardioversion. And each one of these patients underwent a TEE to look at the annular atrial contraction, and they looked at this in AFib, again immediately after sinus rhythm restoration, and again 6 weeks after cardioversion. So they looked at the severity of mitral regurgitation. In AFib, these patients had some degree of mitral regurgitation. Also, immediately after sinus rhythm restoration, there was the same degree of regurg, but 6 weeks after restoration of normal sinus rhythm, the severity of regurgitation significantly decreased. They looked specifically at the annular shape at different stages of the cardiac cycle, and they compared the annular area in atrial fibrillation versus 6 weeks post-cardioversion. And what they saw was that there is significantly better annular contraction, specifically in the presystolic phase of the cardiac cycle. So in blue are the patients in atrial fibrillation, red represents patients in sinus rhythm. So the idea is because the annulus contracts more effectively in presystole, the annular area is smaller, and as a result, the leaflets are better able to coapt, and this leads to significant reduction in the MR severity. I'm going to touch briefly on the management of atrial functional and ventricular functional MR. This was included in the most recent ESC valve guidelines, and there are two distinct pathways for the management of atrial and ventricular functional MR. The first step is to optimize goal-directed medical therapy. So in ventricular functional MR, the first step is to optimize GDMT and to consider CRT if indicated. On the other hand, in atrial functional MR, the first step is to optimize medical treatment, including rate or rhythm control. In patients with severe symptomatic ventricular functional MR, despite optimization of medical therapy in the absence of concomitant coronary artery disease, as per the new guidelines, there was an upgrade of transcatheter edge-to-edge repair, which is now a Class 1 recommendation to reduce heart failure hospitalizations and improve quality of life among these patients. These are the clinical and echo criteria outlined by the ESC guidelines to predict outcome improvement in patients with ventricular functional MR. And they emphasize that patient selection should be done carefully. So these criteria include the absence of severe pulmonary hypertension, severe RV dysfunction, as well as the absence of coronary artery disease requiring revascularization. And this criteria essentially was based on 2 randomized clinical trials showing the prognostic benefit of transcatheter edge-to-edge repair, which are the COAPT and the ReShape heart failure 2 trials. On the other hand, there are few additional recommendations for patients with severe ventricular functional MR with concomitant coronary artery disease. There is a Class 1 indication for mitral valve surgery in patients with severe ventricular functional MR undergoing CABG. On the other hand, in patients with non-complex CAD, PCI followed by transcatheter edge-to-edge repair after re-evaluation of the mitral regurgitation could be considered. So even after transcatheter edge-to-edge repair, the guidelines recommend close follow-up of patients with ventricular and functional MR, clinical lab and echo evaluation every 3 to 6 months according to the heart failure stage is recommended. Durability of the procedural results as well as volume status and the need for further GDMT optimization need to be reassessed, and patients must be educated on the importance of not discontinuing GDMT after the intervention. The new guidelines also outline management strategies for patients with atrial functional MR, and there is a new recommendation for mitral valve surgery and surgical AFib ablation in symptomatic patients with severe atrial functional MR despite optimal medical therapy. On the other hand, transcatheter edge-to-edge repair may be considered in symptomatic patients with severe atrial mitral regurgitation who are not eligible for surgery after optimization of medical therapy, including rhythm control when appropriate. There are no randomized control studies comparing interventions versus conservative medical management in atrial functional mitral regurgitation, so these recommendations are primarily based on retrospective studies. So again, in patients with atrial functional MR, undergoing surgical or transcatheter intervention should be followed up on a yearly basis, including clinical and echo evaluation. And in cases of HFpEF as an underlying cause of the atrial functional regurgitation, the guidelines recommend consultation with a heart failure specialist. So just to conclude my talk, we talked about ventricular functional mitral regurgitation, which is mediated by abnormalities in left ventricular function and remodeling. TIER is now a class 1 recommendation to reduce heart failure hospitalizations and improve quality of life in symptomatic patients with impaired LVEF and persistent ventricular functional MR, despite the optimization of goal-directed medical therapy and CRT if indicated. On the other hand, atrial functional MR is mediated by annular dilatation, impaired presystolic annular contraction, and insufficient leaflet adaptation, leading to inadequate leaflet coaptation. And it's usually associated with atrial fibrillation and HFpEF. And we're learning about a new entity called Eclipsed or paroxysmal mitral regurgitation, which is a transient severe mitral regurgitation due to reversible apical tenting of the mitral leaflets, and it can happen in patients with normal LVEF despite the absence of pre-existing LV remodeling and the absence of known coronary artery stenosis. And this concludes my section, and I'll pass it on to Mike, who has more cases for us.
Okay. Thanks, Rana. So to go on to a couple of other cases, these are some cases that came through our lab in the last couple of months that I thought were interesting and worthy to discuss. So the first case I'll discuss is a 40-year-old female who was referred for a thoracic echocardiogram for a possible intracardiac mass. She had a past medical history of bronchiectasis, anxiety, and an asymptomatic first-degree AV block with a PR interval about 203 milliseconds. In terms of her clinical history, she really didn't have any cardiac symptoms. She'd been having episodes of recurrent pneumonia, and due to her history of bronchiectasis, she underwent a CT scan of her chest. And while this revealed some bilateral bronchiectasis with tree and bud nodularity and possible atypical infection, there was also an incidental finding of an ovoid 11 millimeter high density focus in the interatrial septum near the crux of the heart. And therefore, she was referred for echo for further evaluation. And as I kind of was looking more into this is a very common thing that we see through the lab nowadays. Most patients with an intracardiac tumor or mass are completely asymptomatic and typically just have routine imaging that kind of sparks these investigations. Looking at the CT scan, scrolling through some of the imaging, my cursor. Oh, I screenshotted my cursor right over top. That's good. But you can see that there is a ill-defined kind of mass here of different density than the other surrounding cardiac tissue, which is nicely labeled by the radiologist in this type of imaging here. And so these are initial transthoracic images. So apical four-chamber. Can't really see too much in the interatrial septum. There's some dropout there as expected in the apical four-chamber, but nothing kind of too suspicious. Oops, sorry. Next slide here. Again, looking in our subcostal. There's maybe a hint of some shadowing just right here in the interatrial septum, but unless you were looking for it, you could really be fooled and just think that's normal artifact from an echo. But again, nothing clear. Septum looks thin there in the middle. And so if I remember correctly, we had an echo rounds on contrast that morning. And so we had to do contrast. And when we did some contrast here, this is our first pass here. I'll let this run a loop here. You can kind of see something in the right atrium there. super well defined. And then through some off-axis imaging, we can see kind of a mass along the interatrial septum in the right side come into view here. Looks on this picture here that it's small, well-rounded, kind of circumscribed. There may be a stalk, but it's a little bit hard to see. But it looks like it's mostly on the right atrial side, again, in these off-axis images. This is just at a different gain, kind of characterize it a little bit more. I should mention that there was no color across it, any type of defects across the tricuspid valve or mitral valve, no significant stenosis or regurgitation. And again, looking at different off-axis views, we can clearly see something that we wouldn't have seen on non-contrast enhanced imaging. So this led us to do a T, which none of us echo fellows will turn down at this point. And this was the first picture. And so again, we can see this kind of well-circumscribed cardiac tumor just at the crux of the heart, essentially at the level of the AV valves, the inferior portion of the septum. Doesn't look in these views like it's protruding or causing any valvular abnormalities. Just gonna go to the next picture here. This is zoomed in a little bit here, kind of coming in and out with the cardiac cycle. This is zoomed in here at a different angle, where you can see it's just kind of abutting the retroaortic space there. Second, let's play this again. Again, looks now that we zoom in like it's almost encapsulated. There's kind of, it's not, it's a bit heterogeneous. It's kind of different densities, maybe some calcifications as well. And here is probably the best image where you can see that it looks like it has just like a little shell or encapsulation around it.
It's almost like an egg.
Almost like an egg, yes.
Has a shell, has something inside.
It's exactly how I described it in my report, which Kim promptly changed. You can see going through color here, we did this in a variety of different angles to make sure there was no kind of associated defects. Importantly, which I didn't show here, it's important to look at all of the anatomy around and make sure there's no kind of extension of tumor or thrombus anywhere else, just given some of the associations. Careful evaluation of the IVC and other structures. So this is with contrast here. You can see that it still looks like dark, so it's not necessarily taking up the contrast. That's a flash there, which we'll talk about in a second. Again, if you're scanning with Kim, you get free sound effects for the flash. He makes explosive sounds right there. But again, no kind of clear uptake into the mass.
So there's not a lot of vascularity.
There's just some 3D images we did kind of for fun. As you can see here along the interatrial septum, and then here as well. And there was no kind of surrounding defect or anything. And so, as Dr. Chow was mentioning, kind of some of the points for contrast in intracardiac tumor evaluation is that, of course, the use of contrast can help the endocardial border and definition, but for vascularity, which is probably one of the most important things when you're thinking of intracardiac tumors, we use something called first pass contrast, where we're actually seeing the initial bubbles go into the heart. And so if there's high vascularity in the tumor, you'll have rapid uptake of the contrast when you initially see the bubbles coming in. So that's called our first pass image. And then we also do this flash, which is basically where we use a high mechanical ultrasound index, and that destroys all the contrast micro bubbles. And so you're kind of starting from scratch again, where if there's higher vascularity, you see rapid filling with the contrast micro bubbles. So you can just kind of see flash, and then you can see if the microbubbles are filling the lesion. This is a video of her MRI, she got promptly afterwards. So we kind of see, again, this well-circumscribed mass, more so in the right atrium. towards the
Just
crux of
point
the
it
heart.
out for the audience,
Oh, yes, right here.
just in case.
Yes, it's a good point.
Oh,
And so overall, it was described as kind of similar characteristics to the CT. The MRI is able to characterize a little bit further. So they agreed with our echo assessment that there's a smooth capsule, no apparent stalk. In terms of trying to characterize what type of tissue it is, they use a variety of sequences. And so it doesn't really appear like fat. It more so matched a consistency of the myocardium, but still it was lower than that. So it wasn't clearly the same consistency as muscle. It did comment on a hypointense core, which presumably is like a fluid characteristic, essentially. There was no kind of vascularity at all or uptake, and no late gadolinium enhancement into the mass. And so we were a bit perplexed when we initially saw this because it didn't really fit anatomical, essentially, place that we were familiar with, and it had a lot of unusual characteristics. And so when we go through our differential diagnosis for intracardiac masses, we think of primary and secondary cardiac tumors, lipomas or lipomatous hypertrophy of the septum, a variety of cysts. There could be infection or thrombus or artifact. As mentioned, one of the most important characteristics is looking at the perfusion. There's a variety of imaging techniques that we use. And so the anatomy can really kind of help you out. This is a picture of the Braunwalds, which kind of goes through essentially the different cavities in the heart and where lesions or masses are more likely found. In the kind of crux of the heart there, it's a bit of an unusual spot and doesn't really clearly fit with any of these tumors along with the characteristics. And so we went to looking through a bunch of case reports, and we kind of saw these pictures, which looked very, very similar to what we were seeing. And so there are case reports of this tumor called cystic tumor of the AV node. It was previously called mesothelioma of the heart because of the pathology showing mesothelial cells in the capsule. But that was changed to this because mesothelioma in medicine has a very different kind of aggressive cancer in the lung that is called that. So to avoid kind of confusion between the two, this was kind of recharacterized as cystic tumor of the AV node. And so the T findings are classically this well-circumscribed encapsulated mass in the crux of the heart there. Typically, it has a variety of components, both cystic and solid components, and there can be calcification, which we can see in the transthoracic or transesophageal images there. Typical MRI findings are kind of what we saw. So the location is very characteristic, just adjacent to the tricuspid valve. It tends to have this hypointense signal that we saw. And then although it wasn't as characterized on the MRI here, classically the material is kind of this thick amorphous material. It's basically keratinous debris from squamous cells. One thing that has been described in the case reports that can help in these tumors is that they can have LGE similar to a myxoma, but obviously doesn't look like a myxoma. That's one of the characteristic radiographic findings, which we didn't see on ours, but that is what's described in case reports. Overall, they're very rare, and provided the diagram here to show where the AV node is, and typically it's right around this area, so in between the AV node, coronary sinus, and tricuspid annulus. And so looking through kind of the literature, there's only a couple hundred case reports. Most of them are incidental or actually post-mortem, and the reason that it's post-mortem is because these are associated with sudden cardiac death due to advanced conduction abnormalities, which appear to happen really at any time. And so surgical resection is very recommended due to this arrhythmic risk. So this patient was referred on to cardiac surgery specialist in the city. I saw in the chats, did she have any AV block? She did have a first-degree AV block on her ECG. I actually thought I had a picture of that. Sorry, I don't have a picture of that. She had a PR interval of 203 milliseconds. She did have a 2-week Holter to evaluate for any higher risk conduction disease, which there was no evidence of. But the first degree AV block also kind of fits with this pathology. Okay, next case.
So before you go on to that, I think it's worth mentioning who did the echo actually, transthoracic. You still remember?
I remember.
Anyway, whoever did it actually did a fantastic job because
Yeah.
I mean, 2D pictures
We're waiting to see what he said.
may not have recognized it. You actually pay attention to this. So it's not infrequently these could be missed somewhere, and then they are picked up later on. And so kudos to whoever did it.
Yeah. And all the off-axis imaging, which really characterized it, because even you couldn't really see it that well with contrast on the initial views. So it was scanning through the subcostal views to try to look at the interatrial septum.
Atrial mass is actually a bit more challenging for contrast because it's in the far field. So there's a risk of attenuation from contrast that fills the ventricular cavity. So I think this case kind of is helped because it was fairly inferior aspect. It was almost at the base of the ventricular septum, the inferior aspect of the atrial septum. It was more superior than more challenging.
Yeah, one thing worth mentioning is for standard echo imaging planes are used for screening purposes, meaning that you go through it and it only cut through certain parts. Often things are actually outside the standard plane, so it's really required our sonographer colleagues to think to actually do all the off-axis view. So it's when you get to the advanced stage, that's where the off-axis will do the real pictures for you. So thank you, congratulations.
That's why they like doing the sweeps so often.
Especially in pediatrics.
So much sweeps in the lab.
We used to do videotape and just leave that on.
Mike, it's Bob.
Bob.
Yeah.
I don't understand the surgical option. I mean, if it's the AV node and AV block is kind of the problem, I mean, you could treat it with a pacemaker. And the surgery would seem to me to almost be guaranteed to give you AV block.
Mm-hmm.
And if the tumor is not really malignant or going to grow or do, why take it out? Why not just leave it and put a pacemaker in?
Yeah, I know. I was thinking about that as well. If it was me, I'd probably just like a little epicardial lead. And
maybe I'll just add back to it. It was actually, this case was reviewed 2 weeks ago in the CAF round as well. I think the end of that discussion is like one of that, what you propose is the differential diagnosis and usually it's an expected management unless they are symptomatic. And this patient was referred on, I think, to Dr. Cusimano, who is one of our experts in cardiac masses within Toronto and GTA area. So I think that was the plan at that particular meeting.
Yeah, Chiming and Bob. No, Bob, this is obviously a very unusual diagnosis. The case series that we found in the literature show they unfortunately have quite a malignant outcome. They have a lot of ventricular tachyarrhythmias and there's a number of cases of sudden cardiac death. So that's why they do recommend excision for these. It's, we're talking a very small number of cases, but they're almost all malignant in nature. So that's the unfortunate recommendation for surgical excision, which was why RJ is being consulted.
Yeah. RJ actually was involved in a lot of the case reports, so he has some experience, which is very helpful.
Well, we all learn something every day.
Okay. So third case here is 32-year-old female, 30 weeks pregnant, referred for a transthoracic for shortness of breath. It was mainly on exertion. She was getting a transthoracic echo to exclude any structural heart disease. There was no kind of like high-risk clinical features to suggest an evolving cardiomyopathy or significant valvular pathology, but just to make sure everything was okay, she had a transthoracic. And this demonstrated an enlarged coronary sinus in isolation. And so she was referred back for repeat TT to kind of assess for further pathology or cause for this coronary sinus dilation. And so when we think about causes and definitions of coronary sinus dilation, normal coronary sinus diameter is about less than 1 centimeter, typically visualized in the parasternal long axis or some of the off-axis apical views. 1 to 1.5 is generally called enlarged, but greater than 1.5 is definitely kind of enlarged and almost always pathological. Differential diagnosis for this is a variety of things, but in my mind, it's easiest to split it up into elevated right-sided pressures causing dilation of the coronary sinus, such as pulmonary hypertension, severe TR, or RV dysfunction. And then another reason is if you have enhanced coronary sinus blood flow. So if you have a thoracic venous abnormality, such as a persistent left-sided SVC, if you have a coronary artery fistula into the coronary sinus, or if you have a coronary sinus ASD, which is typically associated with a persistent left-sided SVC. And so for those in the room or online that aren't familiar with a persistent left-sided SVC, this is one of the more common, or I guess pathognomonic causes of coronary sinus dilation. So typically there is a vein here that connects directly into the coronary sinus in embryology, and this typically becomes atretic. But if there's failure of this to regress, you get essentially a persistent left-sided SVC. So instead of going across the left brachiocephalic vein into the SVC and into the right atrium, you essentially have this connection here between the two. And so you can see that there is essentially drainage from the left-sided upper extremity structures, which go directly into the coronary sinus here, and then directly into the right atrium. So it almost bypasses this kind of normal transit period here. And so these were our initial images in the parasternal long.
Might have to dim the light.
Yeah.
It's hard. And,
Or up the gains, but unfortunately.
yeah, keep going.
Yeah,
There you go.
perfect. Okay, so we have our parasternal long, and this is our coronary sinus right here, which is prominent and dilated. RV function looks okay. LV function looks okay. There's no real significant valvular disease. There's a bit of TR, overall quantified as mild. Here, see the coronary sinus coming in there. And then one of the ways that we actually test for these thoracic venous abnormalities is we do bubble injection into both the right and left arm. Sorry, distract. And so what we do is we inject into the left and right arm. And if there's a persistent left-sided SVC, we expect that the coronary sinus will fill first with bubbles or agitated saline before the right-sided cardiac structures, because that's the anatomy. And so you can see the coronary sinus light up here, and then the right-sided structures, and got to be quick to kind of visualize it. I'll go right from the start again. You can see that it clearly opacifies before the right-sided structures there. It is like only like half a second before, so you have to sometimes slow it down. But we can see that. And then one helpful trick is we can do M mode. So if we do M mode through the coronary sinus and the right-sided structures, we can actually see that the coronary sinus opacifies here about one cardiac cycle before the right-sided structures, which is a beautiful example here. And then we did the right side for fun, but also to see where it would go. And lo and behold, the coronary sinus lit up first again. So if I go back to the start here, we see coronary sinus opacification and then the right-sided chambers, which is a bit unusual. And if we go to this inflow view, we can see the bubbles coming very nicely directly from the coronary sinus, just in the left lower corner right here. And again, this is with the right arm injection. So we typically expect it to come just from the SVC into the right-sided structures, but we see it directly coming from the coronary sinus. So again, I learned something that day with anomalous venous drainage. Although persistent left-sided SVC is the most common, it is one of the kind of things that comes up on exams. There's a number of vascular abnormalities that can be associated with this. And so both are relatively rare. It's a bit more common in congenital heart disease, but most common is just your isolated persistent left-sided SVC. But you can have loss of crossover variants or even absence of the right-sided SVC, which again is only described in a handful of case reports. And so this is what the anatomy can basically look like. So you can have your normal anatomy here, where you have, they're just missing the brachiocephalic vein here, but most of your side all goes to the right side. You can have your persistent left-sided SVC, where it drains right into the coronary sinus. You can have your persistent left-sided SVC, where there's a fenestrated ASD. You can have your persistent left-sided SVC and a variety of bridging veins. There can be one or there can be two. Or you can have complete absence of your right-sided SVC going into the right atrium, and it all goes through a persistent left-sided IVC. And so in this case, it's either D or E here, and CT imaging would confirm. Clinically important, now that we're putting catheters in everyone or wires in everyone or lots of percutaneous options for a variety of treatment options, this mainly has clinical implications for patients as they age, just for pacemaker, ICD lead placement, as well as if you're on medicine, putting in a central line as a PGY1 and you notice that it's taking a very abnormal course near the aorta, that becomes clinically relevant. Retrograde cardioplegia may be ineffective because that's where you inject into the coronary sinus if it has leaking into the systemic vasculature as well. So it's relevant for that. Most of the time, it's best to just characterize the anatomy with a venogram or a CT scan to kind of have with that patient along their lifetime to avoid procedural complications.
So I think Will has a case, right, this weekend?
Yeah, I put it in,
Yeah. So for that, I have like patients that I identified, either in the echo lab or in my clinical practice. I basically make sure they have a copy of the echo, and I make them actually take a picture of the echo report and put it in their phone in the private area in the phone, so that in case it needs to be instrumented for a variety of reasons, pacemaker, central line, they will be able to tell you. But the other thing that you could have a suspicion of it is if you do a POCUS on it, you see a dilated left coronary sinus beforehand, then you will actually pick that up as well. But I make sure my patients have like ECGs and echo report, just make sure they're actually in a private, secure area. Then I have to teach them in clinic how to do that. Okay, anything else?
No.
That's it. Okay, well, thank you so much for your wonderful faces today. So I want to acknowledge all our Echo Fellows who have worked very hard. They have started now for 3 months. They've progressed really well and contribute significantly to our Echo rounds as well as clinically. And these rounds are great because these are real life cases that come through, and I think we should encourage to do more of it. And that's how we used to do it. And then, some didactic lecture reviewing the guidelines and also these kind of educational cases that we see in real life. So thank you so much for all your hard work.
Yeah.